Good morning, dobro jutro. Welcome to Zagreb. Welcome to the Human Rights and Childbirth Eastern Europe Conference. It's very exciting to see such a full room of happy and excited faces. Thank you all for taking the time to come, and thank you for recognizing that human rights and childbirth is a human rights issue. My name is Daniela Drandic. I'm the head of the Reproductive Rights Program at Croatia's largest parents advocacy organization, RODA, Roditelji u akciji, which means essentially Stork, Parents in Action. I've got a few service announcements to begin with at first. So we've started a few minutes late, which we kind of expected, so everything's going to be moving just about 15 minutes later. We've got, at the registration desk, we've got two types of mugs that we've got for sale. So one of them are Boycott Nestle mugs, and the other ones are Human Rights and Childbirth mugs. So if you're interested, go and take a look. We've also got these neat little bags with Human Rights and Childbirth logos and whatnot on them. So if you're interested in anything like that, they're located at the desk. Each of you should have in your bags a Lancet. So if you don't have a copy of the midwifery series from the Lancet in your bag, that means we gave you the wrong bag. It's not a big deal. You can just go get a copy of the Lancet up at the registration desk during the break. The coffee breaks take place in the room that's just over on the side, and the lunch will be downstairs in the hotel restaurant. So everybody's invited to lunch, which is during the lunch break. I think that's about it. Yes, and for those of you who are speakers, our office manager, Eva, has come. Yay, Eva. She's in the hallway, so with regard to travel documentation and whatnot, you can settle that with her. I guess it's time for us to begin then. I'd like to begin by, first of all, thanking you again for coming, and thanking Human Rights and Childbirth for choosing Zagreb as the location of the conference. This is a topic that's very timely and very important. We've worked very hard for the last 4 months to get our program together. Elena and I have been working tirelessly over Skype and various other media to get you all together. And I think Elena actually has prepared a stunning program. So can we just have a round of applause for that? First of all, I'd like to tell you a little bit about RODA. This is Croatia, for those of you who are here the first time. And these little storks are all the cities in Croatia where we have had actions, or we have members, or we have done something. So as you can see, we've been located quite a ways throughout the country. Here is Zagreb, approximately. This is the Adriatic coast. Here is Slovenia, here is Italy, and this is Bosnia. Over here we have Serbia, and up here at the top is Hungary. So as you can see, we're quite located in the middle. RODA was founded in 2001 after the Croatian government drastically lowered maternity benefits in Croatia by a group of very enthusiastic mothers who felt that this was an injustice. Since then, we've worked tirelessly in a number of different areas. Currently, we're the largest parents advocacy group in Croatia, and we're active in a number of areas. We are organized in 4 main program areas. So reproductive rights is obviously what we're dealing with today. We also have a breastfeeding promotion, protection, and support program, a parenting program, and a legal advocacy program. We are an organization that was founded by volunteers, and an organization that is very proud of its volunteers. So we're about 150 strong with 60 active volunteers. Currently, we have 5 full-time employees, and we have a social enterprise that has 2 employees. Over on the side, you'll see Tiana, the head of our social enterprise. We manufacture and sell cloth diapers and materials that go along with cloth diapers, so you can visit her during the breaks. One of the things that sets us apart from other NGOs in the region especially is that we put a very, very high emphasis on ethical financing. So we are very careful in whom we take money from, how we take money from them, and what business activities they're involved in. These are our volunteers, which we're very, very proud of. And these are some photographs of some of our actions that have taken place. And that's about it, about RODA. Elena?
Well, thank you all for being here. It's been really a whirlwind I would like first to thank Rhoda for hosting us, and especially Daniela, who has worked tirelessly, really, to make this conference happen. As you heard, we only started 4 short months ago, and I'm really happy with the result. It is great to see you all here. It is just amazing to see so many people who are working and interested in human rights in childbirth. We have, I think, 25 countries represented today, and some of them are coming from as far as New Zealand and Ecuador. So this is really something amazing. And the conference is regional, focusing on Central and Eastern Europe, and I think it goes to show that what happens in one part of the world is not isolated from the rest and really might have an impact. It also shows that there are people throughout the world who are interested in human rights in childbirth and actively working on that, and that we're not alone in this movement. And this feels great. When I started working on women's rights in childbirth in Bulgaria about 5 years ago, I can tell you that we felt very much alone, very isolated. We didn't know that there are organizations in other countries. I think because of the difference in languages and because of the fact that information is not readily available in English, it was hard to know what they were doing. We have spent hours with Google Translate just trying to figure out, what childbirth with dignity in Poland was doing, or what El Parto Nuestro in Spain was doing, and it was very inspirational. To see that there were others involved in that movement. We also didn't really understand the gravity of the issues. I think that at first we thought it was maybe it was just Bulgaria or just the region, but we didn't realize that this was a problem that is spread throughout the world, that it doesn't matter if the country was resource rich or resource poor. It didn't matter how much they spent on maternity care. You could still see abuse and disrespect of women in childbirth, and I think that really came through when a landscape analysis was done by Bowser and Hill. Was a project by Traction USAID in the United States, and what they did was they took research and reports from every region of the world and just reported them. And what they took out from that research were that there were several types of abuse and disrespect present. So before, when most international organizations were talking only about maternal mortality as a serious human rights issue that affected women, in 2010 we started realizing that there are more issues, more human rights issues involved. There were issues of privacy and respect. There were issues of dignity, informed consent and informed refusal, violations of discrimination and childbirth. So this really opened our eyes to the whole spectrum, and it became clear that this is not an issue that involves just a few providers that are behaving that way. It is very much a structural issue, and what we realized we needed is a movement. Really, we needed more people and more organizations to be involved so we can figure out a way to resolve that issue. In 2012, when the Hague conference was announced, we were just so excited that there was a large event like that drew so many people from so many different backgrounds. It was just amazing to see so many people coming together to speak about this one issue. And the whole conference was organized around the case of Turnovsky versus Hungary, which is an amazing landmark decision by the European Court for Human Rights, and stated that women had the right to choose the circumstances of childbirth. I think this is when that movement was born, because we could connect with other people. We managed to establish networks in different countries, and the rippling effect of that conference are still felt today with this conference, with conferences in Western Europe, in the United States, and later this year in South Africa and in India. This I cannot express how excited I am to see that happening. In just this past Saturday, April 11th, was the International Day for Maternal Health and Rights. This was chosen by advocates just last year. So this is the second year we have celebrated this event, and 1,800 organizations took part. This is just amazing to see, and I'm sure that many others would have liked to take part, they just didn't know about it. So hopefully by next year, we would have more organizations in that celebrating that day. April 11th too is the day when the world lost Sheila Kitzinger, and she was a social anthropologist, and she was an amazing advocate for women. She believed that women that experienced birth trauma had to have somebody to talk to. They needed to have that opportunity, and she established a crisis hotline where women could go in and just explain what happened to them. Just talk to somebody who could hear what happened to them. I really hope that that we would remember her each year on that day, as we celebrate the International Day of Maternal Health and Rights. The conference that we have planned for the next 2 days is comprised of 6 panels, 3 per each day, and 2 workshops for each day. We would talk about regional research, advocacy, and litigation efforts that were undertaken here. We would talk about challenges that we face, some of which are very unique to our region. And tomorrow we will talk about accountability mechanisms, starting with local accountability, regional at the EU level or the Council of Europe level, and international accountability mechanisms, because this is very important as we talk about violations of women's rights in childbirth. I really hope that you take the opportunity during the breaks, during lunch, or before or after the conference, to network with each other, talk to each other, especially people that you haven't met before, people from different countries. I think this is how ideas are born, usually by those interchanges. So just take the opportunity to really explore what other people are doing, what their ideas are, maybe plans for cooperation. This is really what the Human Rights in Childbirth conferences are for, to start, to encourage those exchanges. Thank you. And now for the keynote address, we have invited Stefania Karpozewski, the Executive Director of the Hungarian Civil Liberties Union.
Thank you, and welcome everybody. I have to apologize in advance because I have a little bit of sore throat, so I might be coughing during my address. So I am Stefania Kaproncai, and I'm a human rights lawyer in Hungary. It is indeed a great honor for me to offer the opening remarks to the first Human Rights in Childbirth in Eastern Europe conference. I actually vividly remember when I received an email from an enthusiastic American lawyer living in the Netherlands asking me about the Ternovsky versus Hungary case, the home birth case of the European Court of Human Rights. And this lawyer was Hermine, who is probably watching us at the moment as well. Frankly, I was surprised that people outside of Hungary and outside of a relatively small circle of human rights lawyers and mothers not only have heard about this case, but also understood the importance of it. The court has ruled in Ternovsky versus Hungary that the right to privacy contains that women have the right to choose the circumstances, including choosing the place of giving birth. Fast forward several months, I found myself with Anna Ternovsky, the woman the case is named after, in The Hague, in a room full with very brave and smart people from various backgrounds, from various parts of the world. And that was the pivotal moment when the Human Rights in Childbirth movement was born. When I look around today and when I was reading the list of speakers, I see again people from various backgrounds: mothers, activists, lawyers, human rights advocates, researchers, midwives, doulas, journalists, people representing international organizations, OBGYNs, neonatologists, and so on. And I probably left out some. Okay, sorry about that. The diversity of the crowd, I found it both hopeful and symbolic at the same time. The diversity is symbolic of the many types of professions, people who demand say in women's choice about whether or not to give birth and how to do so. There are so many people who demand say in decisions in women's choice over their own bodies. This is a diverse crowd. However, I must say that proportionally, there are fewer male doctors and politicians than the usual when it comes to being vocal about what women shall do with their bodies. At this point, I wanted to mention also a special somebody who we are missing today, who has sadly passed, an inspirational leader and advocate, Sheila Kissinger. Unfortunately, I never had a chance to meet her in person, but I'm really sure that she would enjoy being her, and judging from her interviews, I think she would fill the room with her spirit. The topic of human rights in childbirth, as Elena has mentioned already, is a relatively newcomer to the reproductive and women's rights agenda. The movement was traditionally more concerned with women not wanting to have children. However, the rights violations in childbirth are very similar to violations in other women's rights issues, and they're all deeply rooted in the ideology of paternalism. Therefore, it is difficult to say something new about the phenomenon of paternalism and women's choices, because in the past decades there were so many things said and written about this. I will give you a few instances to get an overview of what is going on in other women's rights issues other than human rights in childbirth in our countries. In our countries in Eastern Europe that we represent here are among the developed countries. Many are members of the European Union. Women still often face oppression, and paternalism is part of everyday life and politics in our countries. Access to contraception is often subjected to ideology-based policy making. What is alarming is that the percentage of seats held by women in national parliaments are shockingly low in countries of the European Union. According to data from the World Bank in 2014, there are about 24% of women of the MPs in Croatia and Poland. The same percentage is 21 in Greece. In Bulgaria and Czech Republic, there are about 20% of the MPs are women in the national parliaments. In Turkey, 14%. In Hungary, 10%. Women's choices are at the hands of legislative bodies, mainly consisting of male politicians who decide about the amount of control over female bodies. Predominantly male politicians view contraceptions in many countries as something sinful. Especially the need for emergency contraception is seen as only women shall be blamed for. Abortion is probably for the longest time on the agenda of reproductive rights activists. The Center for Reproductive Rights has published a report in 2014 under the title Map of Progress. This map shows that since 1994, 35 countries have expanded the grounds on which women can access abortion services. Despite the progress, there are alarming tendencies in European countries that pride themselves in being the cradle of civilization. Starting with my home country, Hungary. Hungary has enshrined into the constitution that fetal life deserves protection from the moment of conception. And just recently we have heard news from the United States how harmful this can be. This and public statements by the state officials about abortion have created an atmosphere in which restrictions of access to abortion can be realistically expected. In Spain, the government has eventually withdrawn its drastic proposal that would have made abortion illegal except in case of rape and when the mother is at risk. At the same time, there's an ongoing campaign calling on Spain's ruling Popular Party to withdraw a bill that would force 16 and 17-year-old girls to obtain the consent of their parents to terminate a pregnancy, even in cases in which the requirement could place them at risk of serious conflict, violence, or abuse. In Lithuania, there was an amendment proposal in 2014, which was an attempt by the state to regulate public morals at the expense of women's right to privacy, health, and life. Although abortion is currently legal in Romania under certain circumstances, in the last few years there have been repeated attempts to impose excessive limitations to exercising that right. In 2012, there was a draft bill that sought to make it mandatory for women seeking an abortion to first attend a counseling session during which women would have to see videos and images showing that abortion is in fact a termination of life, after which they would have to wait 5 days before finally being able to access abortion. Poland is long known for its restrictive abortion laws, which are even made harsher by the reality because of the abuse of consent clauses. Public health insurance in Bulgaria does not cover any methods of contraception nor abortion unless it's performed for medical reasons. Violence against women, domestic violence, is probably the most brutal representation of oppression of women. The ways in which authorities handle these cases and the reaction of politicians, decision makers to those cases becoming public shed light on the real state of gender equality in the countries. Turkey is notorious for its abuse of women. Despite the topic being the taboo, however, the brutal murder of a university student after fighting off an attempted rape has triggered public uproar. And this public uproar actually resulted in thousands of Turkish men wearing miniskirts in protest of violence against women. This will bring me also to the point why I find the diversity of this crowd immensely hopeful. Whether about having a child or the way to have it, women often meet judging, public shaming, public disapproval about their choices. Childbirth is no different in that regard. I have collected a couple of characteristic or representations of paternalism. All can be parallel to the previous examples that I mentioned that underline the similarity of this and other women's and reproductive rights issues. First, women wanting to make a decision about their life and their bodies are often labeled as selfish. These reckless women do not understand that this is about the baby. They should consider the interest of the child. How many times we have heard this? Women are not only reduced to a mere vessel of future generations in debates about abortion, but our privacy and dignity is similarly infringed by disrespectful and abusive treatment in childbirth. Women's consent too often not sought because the only issue taken into account is the presumed interest of the child, but the presumption is made by strangers, like doctors and politicians, and not the mother. Second, we will hear about the overuse of care, too many interventions in childbirth from presenters. One read of this can be the representation of paternalism as well, the representation of the belief that women are incapable of making decisions about their own bodies. Women cannot be even trusted with birth, which their bodies was designed for. Therefore, instead of supporting the natural process, be it in hospital or at home, women's bodies are subjected to interventions. Too many times, these interventions serve the convenience of the caregiver staff or the doctor, at least partially. Thirdly, the issue of gender equality and the proportion of women in decision-making bodies in charge of critical policy making must be mentioned as well. Women rarely make it to the top hierarchy, to the committees, to the gentlemen's clubs. Predominantly male professionals set the rules of the game. For instance, in Hungary, there's only one female doctor in the Obstetrics and Gynecology Professional Committee among the 18 members. Fourth, Professionals enabling women to make the choices they deem the best are often penalized for their support. The sentence to 2 years of imprisonment and the deprivation of liberty of Agnes Garib is a sad example of that. Agnes's freedom of movement is restricted since 2010, almost 5 years now. She was sentenced to 2 years of imprisonment in 2012 for not following the rules of a different profession than under which she acted. This sentence, in which the supporting expert witnesses were not considered as such, has come after years of harassment of Agi and other midwives in Hungary for offering an alternative to women. 5. A frequent way to restrict women's choices is limiting funding to certain procedures. The lack of financing of abortion services, for example, harm the most deprived women. The now adopted, after the Ternovsky versus Hungary case, adopted Hungarian legislation on home birth also excludes state finances for home birth, even if the women have paid health insurance like everyone else. These policies send the message that you might be allowed to have your choice, but the state will only pay for the right one. Not only expressive regulations can contribute to the restrictions of women's choice, informal payments play a huge role in limiting impoverished women's choice when it comes to decision about the circumstances of giving birth. But in the beginning, I said that there's a hopeful read to the diversity of the crowd in this room. As a lawyer and an activist, I would be less positive if it was only lawyers and activists in this room today. The diversity, both occupational and also a bit gender-wise, means that we have already come a long way, made allies who understand the importance of the issue of human rights in childbirth. The issue is put on the agenda of researchers. It cannot be swept off the tables by professional committees of doctors. Even the WHO, which is frankly not the most progressive institution in the world, has issued a statement about the prevention and elimination of disrespect and abuse during childbirth, urging for greater emphasis on the rights of women. The fact that we have come a long way does not mean that we can lean back and enjoy our coffee breaks now. I urge you to work on maintaining these cooperations in order to show to the decision makers that these issues cannot be swept under the carpet anymore. I am positive that the professionalism, passion, and solidarity of this crowd will eventually convince all the women that all women's rights are human rights, which shall be the defining principles of policymaking. So with this, I wish you a fruitful 2 days, and I urge you to make many connections to expand this circle of solidarity. Thank you.
Thank you, Stefania. I'd like to just comment on making connections. For RODA, the Civil Liberties Union, and the Birth House Association in Hungary have been excellent mentors, in a sense. Whatever they do, we say we could do it too. So I think that that's very important, and in networking and in working together, I think we can really, really spark change and make change in the region. One person that we forgot to say a special hello to is Agnes Garib this morning. She has been in Budapest for 5 years now, with restricted mobility and restricted access to leaving her home. She did that to serve women. She did that for a passion. And there are midwives throughout the region that do it. There are midwives that travel. There are midwives that attend births outside of hospitals illegally in order to provide women with a choice. And those midwives need our support. I'd like to invite the first panel and the moderator, Wilma Collins from Slovenia.
Hello, everyone. Welcome to panel one. My name is Wilma. I'm coming from Slovenia. I'm here with you today as a mother. I'm a mother of four, and my first birth is the reason I'm a birth activist. Luckily, my other three births are the reason I'm passionately in love with birth. So, what happened at my first birth? Well, after 11 years, I do remember quite well. People say we don't remember, but yes, we do. For example, when I was admitted at a hospital, I was given drugs, and I wanted to know what are they for and what are they. And because of that, I was labeled as a difficult patient. I was really hurt by that. Then I remember my midwife opening my cervix manually, and I cried out in pain because it was excruciating. She said, "I have to do this, you know." And I trusted her. She knows what she's doing, right? But I felt violated. I felt I'm doing something wrong. My body is not working right. Then I remember she was pushing my baby back in and yelling at me to stop pushing because she was not ready for my birth yet. So she was really yelling at me not to push, and I wanted to please her. I wanted to be a good patient. So I stopped. I wanted to stop the urge of pushing, and that was, oh God, I don't find the words for that. I almost felt like throwing up to stop that urge. Well, then she got ready and she performed episiotomy, and I yelled out in pain. And she said, "I have to do this, you know." Well, today I know she hurt my gland and my nerve, and I'm gonna live with that pain for the rest of my life. Sorry. I thought I won't do this, but well, then she was in a hurry. My baby needed to get out really soon, so she was yelling at me to push, even though I didn't feel like pushing. But I wanted to please her again. I wanted to be a good patient, so I was pushing even though I didn't have contractions, and I felt so wrong. My body failed me completely. Sorry. So my baby was there. I was happy. You know, mothers always are when they expect their first baby, and it's there and it's smelling great and it's warm and it's wet and it's yours, and it's just you're in clouds of happiness. And my baby was taken away to be cleaned, and I felt dirty. I felt wrong. I felt like I'm not good enough to be his mom. But it took me many, many years to finally find out that this birth was not wonderful. And I hear and I see this every day as birth activist. Mothers telling me their birth stories, and I know their human rights were violated. And they say, no, 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 it was wonderful, it was beautiful. Luckily, I prepared myself for my second birth a bit more, a lot more. I had a home birth, and it was wow. I could cry now of happiness if I would describe that birth. And another one, and another one. And I'm happy I had the power to face my first birth and to find the strength to find circumstances to have a birth every woman deserves. I would, at this occasion, also invite you. I'm also a founder of the International Home Birth Day because of my beautiful home birth experience. It is supported also by Midwifery Today and other associations. It's every year on 6th of June, so I do invite you to celebrate with us safe home birth practice every year, 6th of June. And just join us. Find us on internet. So thank you to be with me with this story. Now I'm really honored to present Dr. Claudia Hansen. Yes. Co-chair, Committee of Safe Motherhood and Newborn Health, International Federation of Obstetrics and Gynecology, or FIGO. It's your 15 minutes, Dr. Hansen. Thank you.
Okay, and it's up. Very good. It's really a great honor to be here, and I feel a little bit coming to some roots. So in my CV, you can't read that I have 2 children, but I actually got 1 child too young and 1 child too late. And when I got my child too young, I was 18 in Germany, also not trusting any hospital care. So I actually also delivered my first baby home, just thinking in this traditional German society, it was in the 80s, I just can't have a good birth experience. So it's really great coming back. I have gone a long different way now. I'm not practicing anymore, although I'm an obstetrician. I'm working now mainly on global health. And it's also from that perspective that we started this initiative on mother-baby friendly birthing facilities. And please recognize it's not only about hospitals, it's about birthing facilities. We really wanted to be a bit broader and not being too restrictive. It was an initiative of a few people sitting, having a coffee and saying, okay, in many parts of the world now, more and more women actually deliver in facilities, and what they face in facilities is not the quality of care they should receive. We have been a group from this FIGO committee, which is mainly actually concerned about birth in low-income countries. We also got much support from the International Confederation of Midwives, from WHO, from the White Ribbon Alliances and the Pediatric Society for this initiative. And when we started, we thought, we are not sure whether anybody needs our statement, but now I see really that it was actually quite needed. So it's embedded into a human rights perspective, just this, also the simple perspective of availability, accessibility, acceptability of care, and quality of care. And I think what I feel is very important is that we really set out and say every woman has a right to have a positive birth experience and to have a passionate, dignified care, even in case of complications. We see this as an aspect of quality. And every woman has a right to be treated with dignity and respect, regardless of the background or social status, so also youth. Everybody has a right to be with the newborn when the baby is born. And so we had this idea of this is a right of women, but we also thought we have to put something a little bit clear. And we proceeded to make some clear criteria and then also indicators. So that's a bit copied from the baby-friendly hospital initiative, because that's much easier if you go that way and have something concrete. But indicators only indicate. It's not, they are not it's not about indicators, it's about the things actually in the middle, which really make the passionate care. We need something to measure, but we should not strive to meet indicators. We should strive to meet the need of every woman and every baby. So I want you to take this as a home message, even if we put indicators, because we need indicators, it's not about indicators. So we put down a few things which we thought are really important, and that is that women have the right to take their preferred position, that it's non-discriminatory, that there is privacy, choice of taking a birth partner, cultural competent care, no physical, verbal, emotional abuse, affordable cost, no routine practices, and a few others, and I will go in a little bit more what we really meant. So the free choice of how you in particular go through the first stage of labor, we thought it's very important. We know from many studies that you are allowed to eat, that you are allowed to drink, that you don't need any shaving, and that it's much better actually for the birth if you move around. And we have even a Cochrane review saying so. This is the way how it should be. To come to the point of discrimination, so from my own experience, I always feel being young is really a big problem. So you don't get the care actually you should have, because the paternalistic structure of the hospital is even stronger if you are young. And if you see the map here, the data from the European Union, there are some countries really have quite a lot of youth giving birth. Privacy, it's clear what we mean with privacy and what we need is a little bit different in different cultures. So bear in mind, we made this also for an African setting. So this nice delivery ward, which I showed on one slide, we cannot yet have in Africa, where you maybe have a room for every woman. As we have it here. So, but it depends, and it's just a matter of talking also to women and asking them, how do you feel? What would you need to feel really your privacy? And it's often also quite disruptive if you have your baby then, and it's just taken away for some maybe half unnecessary or often actually quite unnecessary procedures. So privacy means that you have your moments which you really need with your partner, with your baby. Having the birth companion we see as something very important. Just again from the context in Africa, this is often not accepted. So this is something quite difficult for many countries. But again, we have a Cochrane review which clearly also supports that this is important and can reduce even cesarean section and need for pain relief. We want to see it really in a rights approach, that women really feel that they have a right, and that's also why in our criteria we really put forward make women aware of rights, make families aware of rights. In the hospital, that it's really clearly put on the walls, and that the hospital really clearly points out to fight against exclusion and marginalization. Dignity and respect, that's the main thing now really strongly coming up. Also in the WHO declaration, and be aware that it spans through many, many different aspects, the physical, verbal, but also financial abuse, like that you have to pay for certain things, or under the table payment. Again, what is okay for a woman and what can be done will be very different in different societies and different contexts. But it can be found in every hospital and in every society that there should be something what is considered really as right, and even this will change. We had quite a long discussion also on the issue of cesarean section. It is quite often so that doctors earn more money with cesarean section, and that will, particularly if you have privatized care, often make doctors to do unnecessary cesarean section. And we think that this practice is really a problem. So there should be some kind of risk pooling, what we have normally in healthcare. So I have no understanding at all why a doctor gets more money for cesarean section than taking care of a maybe long and difficult birth. Evidence-based childbirth. There are so many things which are actually done which are not necessary. And if you see, I plotted here from the latest publication, it just came out a month ago, from the European Union, the reported cesarean section rate, you see that Cyprus has a rate of 50%, Iceland has a rate of 15%, so a huge, huge difference. But the lowest mortality and I think the highest satisfaction with birth you have in the Scandinavian countries with the lowest cesarean section rates. So I'm not speaking against the right of women to decide, I'm speaking against an over-medicalization which is just a practice. And finally, we don't want to see our initiative replacing the baby-friendly hospital initiative. It should take the same idea up, but we try to point out that it's a little bit of continuity, that it's coming from antenatal care into postpartum care, and it goes to this important period after birth. So we want to expand the thinking and really going for moving this forward. So I'm actually extremely happy that people have seen this statement now. I must say that we were very hesitant and thought it doesn't have a place. And I see now that it has a place and that it was very much needed. And so we, from our initiative, we're a small committee, we are clearly looking for partners to move this agenda really forward. And again, it's not about indicators, it's really about getting better care to women and baby who needs it. I put in the link also to the statement, and what we want is really to develop something like a positive emblem. So this hospital, this group of care provider really wants to adhere to be mother baby friendly and put this really as a main branding of a facility. Thanks a lot for giving me the chance. It's really a pleasure.
Thank you, Dr. Hansen. I'm honored to welcome Dr. Alison McFadden, Senior Research Fellow, School of Nursing and Midwifery, University of Dundee, Scotland. There, and if you need, that's here.
Thank you very much. I'd like to add to what everyone said, that it's so exciting and so thrilling to be here and to have the honour to present at this conference. And I've been asked to present about the Lancet series in midwifery, which I was privileged to be part of the team that was involved in that and published last year. So for 2 years, my life was the Lancet series. I'm going to focus the presentation on explaining the framework that's in the first paper, and it follows on really nicely from Claudia's presentation, because I think it could be used to underpin or to provide standards for the mother-friendly hospital. Okay, so very, very quickly, we all know that women and babies have the right to life and health and to special protection during pregnancy and birth. But I think it's also worth also reminding ourselves that in some societies there's just complete lack of women's basic rights. And it's not just about improving services, although of course improving services is very important. And we also all know, and we've heard examples today, that these rights are being violated through not only preventable mortality and morbidity, but also low quality services. So as well as high maternal mortality ratios, even where in countries that have low maternal mortality and infant mortality, there can still be high rates of unnecessary interventions, lack of access to evidence-based care, and using similar examples to the ones that Claudia used, lack of respect, lack of opportunities for women to be involved in the decision-making about their care, and certainly lack of access to midwife-led continuity models of care. So what does the Lancet series have to say about all this? What does it have to offer? And just to point out that we, after a lot of debate, we picked this as our logo, and it's a double-sided key. Midwifery is the key to promoting human rights in childbirth, and it's a double-sided key to suggest there needs to be balance in the system. And you can look at balance in all kinds of ways, but perhaps one would be the balance of normality versus the interventions that are necessary in emergencies. I'm just going to give you a very quick overview of the whole series. I believe you've got copies in your packs, so you can have a look at those. So the first paper, the one that I was most involved in, I'm going to talk more about, so I won't say much about that just now. The second paper, led by Caroline Homer, The Projected Impact of Scaling Up Midwifery, looked at the coverage of midwifery interventions. They modelled the outcomes of upscaling midwifery interventions in countries according to HDI index, and found that they could avert 61% of maternal, fetal and neonatal deaths. And if you add in family planning to the midwifery interventions, that goes up to over 80%. The third paper did case studies on low and middle income countries, and they found that where efforts to strengthen health systems to support midwifery had focused on the network of facilities and uptake of facility and skilled birth attendants, and that there'd been very, very little attention to quality of care and no attention to respectful care or to over-medicalisation. And the final paper looks at coverage and workforce, and concluded that national investment in midwives must include their work environment, their education, their regulation and management, and that can improve the quality of care. And there's two further papers which are forthcoming, hopefully later this year. One which I'm also involved in is a prioritisation of research to benefit childbearing women, infant and families. And the second one, which you might be most interested in, led by Sue Down, will take a human rights approach and look at the role of midwifery in effective interventions to reduce discrimination. So we all await that paper very eagerly. As part of the Lancet group, we came up with a new definition of midwifery. And the reason for that was to put women and babies right at the very centre. So our definition is about what women and babies need rather than a professional project around midwives. So it's skilled, knowledgeable and compassionate care for childbearing women, newborn infants and families across the continuum from pre-pregnancy, pregnancy, birth, postpartum and the early weeks of life. The core characteristics include optimising the normal processes, timely prevention and management of complications, consultation with and referral to other services, respecting women's individual circumstances and views, and working in partnership with women to strengthen women's own capabilities to care for themselves and their families. And every word in that definition was agonised over, debated, taken out, put back in. So hopefully we've ended up with a definition that is fit for purpose and that everybody can feel comfortable with. So here's the framework, and I'm going to take you through it step by step. But a really important point is around the fact that it puts women and babies at the centre. And it focuses on the what of care, the how that care is provided, and the who. So if we start at the top, the green line is about the care for all childbearing women and infants. And that's not low risk women, that's all women. And then we add the orange, which is for childbearing women and infants with complications. But that doesn't mean that they transfer from the green line to the orange line. It means they need all of the green line and the orange line. Then we come to the what of practice, the practices. We sometimes call them interventions, but that led to a lot of dispute about that term because it can be used in quite a negative way, which is why we call them practices. And there are 3 practice categories that all women need. They need education, they need information and health promotion, they need assessment, screening and care planning, and then they need promotion of normal processes and prevention of complications. And if you look at the Lancet series, you will see, based on the all the Cochrane reviews in the pregnancy and childbirth group, the proven effective, the evidence-based effective practices that fit in those different boxes. And then we move on to the needs of women and infants with complications. So we have first line management of complications, and that could be first line as an emergency or a first stage before referring on for specialist services, or it could be interventions that are for minor complications. And the size of that very last box, although we have no idea how many women would need specialist medical obstetric neonatal services, but it's meant to suggest that it's only a few women. It's by no means all women. Then we come to the how of care. So we've heard about the available, accessible, acceptable, good quality services, and that of course requires adequate resources and a competent workforce, continuity of care that's integrated across community and facilities, that's provided with basic values of respect, communication, community knowledge and understanding, and care that's tailored to women's circumstances and needs, and is also provided with a philosophy of optimizing the biological, the psychological, the social and cultural processes, and strengthening women's capabilities to look after themselves and their families, and with expectant management, i.e. using interventions only when they're indicated. And then the who, the care providers, must be practitioners who combine clinical knowledge and skills with interpersonal and cultural competence, and that the division of roles and responsibilities should be based on women's needs and on the competencies and resources available within the setting. And we put this blue line round to suggest what is within the scope of midwifery. And it's got those dots there to suggest that in different settings that might be slightly different. But what's important is whatever you're mapping to this framework, so even if you're mapping obstetric practice, you would have that end box, but you need all those 4 horizontal lines. You still need the organisation, the values, and the philosophy, and the care providers. So just a quick summary. We hope that that framework could be used and tested in a range of contexts. So for planning services, for monitoring services, for education, we'd really like to see if it could be used to develop a curricula for midwives. Midwifery has a particular contribution not only in preventive and supportive care, in preventing complications and in promoting positive outcomes, and that midwifery is associated with more positive outcomes and cost savings when provided by midwives who are educated, trained, regulated, integrated into the health system and within the context of effective teamwork. Okay, so I just want to very quickly tell you about the kind of ongoing work. And we would suggest that from the series, the challenge to the global community and certainly in this region is to respond and use this rights-based approach to meet the needs of women and babies for high quality maternity and newborn care. So midwifery action is the tagline that we're using for the Lancet series. The Lancet wouldn't let us use the Lancet. We have a hashtag, Lancet Midwifery. The website is under development, but on there you will find the papers and you will find interviews, short film clips that were taken on the launch of the Lancet series last year in London. And we also have a Twitter account, so those of you who are tweeters, please look for @Midwifery Action and follow us. But the most exciting thing that's happening is that the Swedish Ministry of Foreign Affairs have picked up the Lancet series and the State of the World's Midwifery and have chosen it for their campaign for 2015. To highlight the need to implement midwifery globally to improve maternal health and empower women. And it's an online campaign celebrating midwifery through storytelling and blogs to share best practice. And it involves co-creative and opinion-forming exploratory events around the world to identify the challenges, barriers, and solutions for getting every woman a midwife. Events planned, they're now actually taking place in Afghanistan, Angola, Bangladesh, Geneva, Guatemala, London, Mozambique, Uganda and Zambia. And there's a major ideation event in New York next month in May, we don't have the exact date yet, where ideas from all the previous events will be pooled and new solutions invented. So watch this space for that. Okay, very quickly, there's a website for Midwives for All, and there's a Twitter account, and that's just some of the examples from the launch in Geneva. Thank you.
Thank you very much to Wilma and to Claudia and to Alison. I'd like to give the floor to the audience to see if there are perhaps any questions that you'd like to ask our panelists. No questions. All right then. We have a coffee break coming up, so just keep in mind that we're about 15 minutes late for everything, so we're going to start again at 10:45.